Hi, everybody. My name is Sasha Eisenstein. We're pleased that you could all join us for this week's lecture in Volume 8 of the KnowNeuropsychology didactic series that brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the KnowNeuropsychology Board, as well as members of the KnowNeuropsychology Committee. We'd like to thank our 2023 sponsors for their generous financial support of this series. Additionally, we're grateful to our International Neuropsychological Society colleagues for their sponsorship and wanted to share information about their upcoming conference. The theme for this year's INS conference is Culture and Connectivity, Neuropsychology Without Borders. It'll be held in New York City from February 14th through 17th. Before we start our lecture, one of the main goals of KnowNeuropsychology is to provide free, high-quality didactic content to our audience. Every KnowNeuropsychology and KnowNeuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to the new content. New to KnowNeuropsychology is our collaboration with AppSyn to bring you learning and discussion questions that are provided with specific lectures content. You can access these on our website through APPCN. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it's my pleasure to introduce Dr. Molly Mather for today's lecture titled Clinicopathologic Concordance in Dementia Syndromes. Dr. Mather is an assistant professor in the Department of Psychiatry and Behavioral Sciences and the Mesolome Center for Cognitive Neurology and Alzheimer's Disease at Northwestern University Feinberg School of Medicine. She specializes in neuropsychological assessment of neurodegenerative diseases and dementia syndromes and works on several longitudinal research studies focusing on aging and dementia. She received her PhD from University of Massachusetts Amherst in 2021 after completing her predoctoral internship at the University of Chicago Medicine and recently completed her postdoctoral fellowship in clinical neuropsychology at the Mesolome Center. Dr. Mather, please take it away.
All right, thank you so much, Sasha. I am excited to be here with you guys today. So, as I mentioned, or as was mentioned already, I'm going to talk about clinicopathologic concordance with you. No disclosures for today's presentation, and just to sort of give a sense of where we're going, we're going to start by talking about the dementia syndromes and sort of how these are categorized into specific clinical phenotypes. Then we'll talk about the neurodegenerative diseases. Then we'll sort of put those two together and grapple with clinicopathologic concordance, which is, as the wording might imply, a little bit messy, a little bit complicated, but that's where it all gets very interesting. So just to start out, this sort of key conundrum here of a syndrome versus a disease is one that often comes up in our clinic. It's something we think about all the time in our research as well. Just this idea that syndrome and a disease is a different thing. So a syndrome is something that's diagnosed at the behavioral level based on symptoms or report of the disease course. It's a recognizable complex of symptoms with possibly with physical findings as well. When you're talking about a syndrome, you don't necessarily have a direct cause that's understood. With a disease, you're talking about specifically a disorder of structure or function. Usually they do have a known cause. And a good way to think about the difference between these two things is thinking about like a fever or an illness. We're going into the fall season. There's going to be a lot of these going around. If you have a fever, you have a sore throat, you feel just kind of off. Those are all symptoms that sort of create this syndrome of some sort of illness. You might treat that with a medication to lower your fever or something to sort of soothe your throat, but those things don't actually do anything to treat the underlying disease or the underlying illness. So it depends, if you have a bacterial illness, they're able to identify what it is, then you can have antibiotics, and that's probably going to be helpful. If you have a viral illness, that's not going to really do anything at all, and sometimes it's actually quite harmful. So there's sort of these two layers of diagnosis that become very relevant when you're talking about dementia syndromes and neurodegenerative diseases more broadly. When we're thinking about this in terms of dementia, the syndrome level, this is where we really function as neuropsychologists. And this is also what's determined based on the course and the nature of symptoms while someone is alive. Actual diagnosis of a neurodegenerative disease at this point still relies on brain autopsy after a patient has passed away. Increasingly, there's biomarkers that can be used to sort of get a pretty good sense of what disease is sort of causing the symptoms. But at this point, we still really rely on brain autopsy as the gold standard. So I want to sort of bring up both of these because it might seem, we're neuropsychologists, maybe it only matters to talk about the syndrome. That's really the level that we operate at. But it also matters to try to figure out what the disease is, particularly if we think sort of about going forward in the field when we do have disease models for various neurodegenerative diseases, it's going to matter which one that someone has. Also, certain diseases can be associated with different responses to even just symptomatic treatment. So cholinesterase inhibitors are useful in Alzheimer's disease and vascular dementias, less useful in certain other types of underlying diseases. We also can hopefully predict better how things are going to go for a patient or for their family, and just help them kind of understand, what our diagnosis means at the behavioral level, at the syndrome level, and what that might mean if we do know what the underlying disease is. So if you think about neuropsych assessment in this specific context of cognitive decline or dementia syndromes, what we do really provides one level of evidence of what's going on. So we're assessing for syndromes, we're looking for patterns in cognitive testing or during interview on questionnaires. And those are all things that we hope point to sort of a specific type of syndrome. And the type of syndrome can help us guess at the etiology. So we're, in other words, matching the testable mind to the measurable brain. We are, existing in that testing area in the living while our patients are living. That's where we are. That's where we live as neuropsychologists. Increasingly, we do have biomarkers that can be helpful. So CSF biomarkers or functional imaging, even structural imaging can sometimes be helpful. And then you actually look at their brain, that's when we get to actually figure out, okay, that's what the pathology is that's underlying these symptoms. So it's really a range that goes from, what we're able to collect and understand in terms of the pattern of symptoms, what those mean for likely what's happening in their brain. And we don't actually often get the answer until pretty far down the line, at least not for certain. So let's talk a little bit about just sort of overview the kinds of clinical phenotypes and dementia syndromes that we see. Before we start that, just to get everyone on the same page, dementia is defined as a decline from prior level of functioning in cognition or emotion or behavior, or all three, that progressively worsens over time and interferes with independence in daily functioning. So we probably all know that many cognitive abilities do decline over time with aging, just normally. That's typical aging in the absence of a neurocognitive disorder. So when we diagnose someone with a mild cognitive impairment or dementia, that requires that there's more decline than just what we would be expected for their age alone or for their sort of baseline level of functioning. So as we touched on before, dementia is really a clinical syndrome. It's diagnosed based on their clinical presentation, not based on the underlying pathology or disease, though we may have more or less of an idea of what that is. So this table, it's a lot of information, but just to sort of go through what this is reviewing, a lot of dementia syndromes present actually rather focally at onset. The predominant symptom then becomes important in diagnosing what that syndrome is and can help sort of identify the diagnosis pretty early on. Because these are progressive conditions, most dementias, if they are far enough advanced, may look relatively similar. There can be symptoms across all domains. But if you catch someone pretty early, usually if there's a focal presentation, that can actually be useful in kind of determining what's happening in their brain. So the most common, the one we sort of, at least in the lay understanding of dementia, this is really what people think of when they think of dementia, and that's memory. So an amnestic presentation. Typically, this is diagnosed as dementia of the Alzheimer's type or Alzheimer's disease dementia, sometimes just called Alzheimer's disease, even though it is a syndrome that we're diagnosing here. This is related to dysfunction or degeneration in the medial temporal lobes, which we know are crucial for new learning and anterior great memory. So it makes sense. That's the part of the brain that's affected first. That's sort of the big first symptom that you see. So main early symptom is obviously memory loss. This can present as rapid forgetting, poor learning, so not being able to actually encode information very efficiently, also poor recognition. And sort of the classical way of thinking about it is, if someone's able to recognize information, then actually they're retaining it okay. But what we often see is really a sort of only a retrieval-based deficit, even very early on, that will then progress to a more recognition-based deficit as well. And symptoms, as I mentioned, will progress over time. Often the next couple of things that are impacted in this amnestic predominant presentation are language, so especially naming abilities, and other executive abilities as well. Then we have our progressive behavioral type dementia, which tends to be related to degeneration, changes in the frontal and anterior temporal lobes. The main early symptom here is, as the name implies, behavioral changes, often comportment changes. You can see disinhibition, poor judgment, reduced empathy. You can also see pretty obvious executive dysfunction on testing, although sometimes patients who come in with, purely behavioral changes will test completely normally on a neuropsych evaluation, and it's really the observations of behavior and the informant report that helps you understand the significant behavior changes. These syndromes often will progress to include language deficits after not too long, and memory loss. It happens down the line as well. We also have our set of progressive language-based dementias. So that puts us in the realm of primary progressive aphasia, or PPA. In these conditions, the degeneration starts in the language areas of the brain. For most people, language is left lateralized, so it's typically more in the left than in the right. The nature of symptoms, especially early on here, can vary pretty widely across different subtypes of PPA. They can range from word-finding difficulties to more frank agrammatism and motor speech abnormalities, or even comprehension difficulties. And these patients will often then develop behavioral symptoms later on, as well as executive deficits. And then last but not least, on these sort of most common presentations that we see here, we have progressive visuospatial dysfunction. So this is, interestingly, clinically diagnosed often as posterior cortical atrophy, which is just a small tangent here. This is a good example of the way that we use language can actually be quite confusing when we're giving these diagnoses. So posterior cortical atrophy, or PCA, that's an anatomical name, but we are describing a behavioral syndrome. Granted, usually that's diagnosed in the context of visible posterior atrophy on MRI, so that is an anatomical change. But when we're using the term to also encompass something that we can tell on testing, then we're kind of mixing, we're crossing over the boundaries there. So obviously this is associated with atrophy posteriorly, so in the parietal and occipital lobes. Early symptoms are visuospatial abilities, and that can be a variety of things. Sometimes you'll see simultaneous agnosia. You can see hemispatial inattention, the Lynch syndrome, and then symptoms progress later on to include language and memory as well. So putting this all into kind of a visual here, this is just a nice depiction of sort of the specific location that these syndromes are associated with in terms of their early symptoms. So amnestic is nestled right nicely here in the medial temporal lobes, visuospatial in the back, behavioral frontal temporal lobes, and then aphasic on the left, mainly in the left temporal and frontal lobes, for people who are have typical brain lateralization for language. So up next, we are going to talk about the different kinds of proteinopathies that cause neurodegenerative diseases. And that, I would say, this area is where I think I've learned the most over the last couple of years being at the Mechelin Center in terms of what are these diseases and how do they relate to our clinical presentation. So broadly, a neurodegenerative disease is one that results in the loss of structure or function of neurons, which ultimately leads to cell death. So these diseases are associated with changes on different levels. So you can see structural brain changes. So sort of an example of the hallmark Alzheimer's disease brain changes here, where you have pretty stark loss of volume in the hippocampus. You see the huge holes in their brain, widening of the ventricles, and just shrinkage overall in the rest of the cortex as well. We also see changes in brain function. So often, if you do an FDG PET scan, you can see hyper or hypo activity in certain areas based on different types of underlying diseases. But really the thing that's underlying all of these things is a process of accumulation of misfolded proteins, and that's sort of the disease process itself. So the assumption is that this process of proteins becoming structurally abnormal and disrupting the normal neural function of those neurons actually is the thing that leads to functional and structural brain changes that we may observe during life, and that then those are the things that lead to the symptoms that we see. So to get a sense of the wide array of proteins that are involved here, before we dive into any more detail, I do want to just make the caveat here that I am certainly not a neuropathologist by training. So my understanding of this is relatively surface level, and it's about as much as I need to understand how it's meaningful for a neuropsychologist. So we aren't going to get too into the weeds here, but certainly I'm going to do my best to kind of make the lay of the land clear to you as it has become increasingly clear to me. So the most common proteinopathy that we know of, that most people have familiarity with, is Alzheimer's disease. If you have any familiarity with Alzheimer's disease pathology, you've probably heard that it's made up of two different types of protein changes. So we have amyloid plaques and we have tau tangles, and that these things together with neuronal degeneration is what causes the symptoms that we see with Alzheimer's disease. So amyloid plaques over on the left, you'll see that nice image there. There's this beautiful tufted area, this fluffy plaque here outside of the cell body. So amyloid plaques are aggregated toxic forms of amyloid, and they form outside the brain cells. Neurofibrillary tangles, on the other hand, are pathologically altered tau protein, which aggregates inside the neurons. So there's amyloid outside of the neurons that's accumulating, and there's tau building up inside the neurons. And the amyloid hypothesis of Alzheimer's disease suggests that abnormal accumulation of amyloid is sort of the first thing that happens, and then that somehow paves the way for accumulation of phosphorylated tau. I don't think we know why that is yet, but that is the current sort of thought, or at least the thought that most of the research has been based on for the last few decades. So this is a lot of information on one page, but I just want to sort of put this up here, that the way that Alzheimer's disease neuropathic change is diagnosed when you're examining the brain of someone who's passed away, it's based on three different things. So it's based on the location of amyloid plaques. So if you look over in the section that's talking about thal phases, and the images over here, thal phase is based on how much of the brain or what parts of the brain you can find amyloid plaques in. You're also looking at what part of the brain you can see tau tangles in. So if we look at the BRAC stages over here, basically the more that these spread out into the brain, the higher the stage is. And they usually start pretty localized and then spread outward into the cortex. You're also looking at the density of neuritic plaques, and that's the CRAD score over here. These three things are all put together. If you have pretty high level of all of these things, then you end up in the high Alzheimer's disease neuropathic change area. But it's sort of staged so that if you have some but not a whole lot of this pathology, That's still acknowledged by the classification scheme, but it sort of is graded appropriately. This is just also another image of these three different things. So if we look at the top right, there's amyloid plaques. This relates to the A criteria, the thal phase. The top left is the neurofibrillary tangle score. That's the Brack stage. And then the bottom here is the CRAD grade. That's the density of these neuritic plaques. And I have only recently started to make any sense of these beautiful pictures. So if you're looking at this and it makes no sense to you, that is totally normal and that's okay. So speaking in more depth about tau proteins, so tau is implicated in Alzheimer's disease, but there's also additional tauopathies that are not Alzheimer's disease that can cause these dementia syndromes. So tau, oops, one second. Okay, here we go. So tau is implicated in stabilizing of microtubules, which are involved in determining cell shape and in a variety of cell movements. So when a cell is healthy and when the tau is functioning normally, it supports cell differentiation, polarization, and other processes involving the cytoskeleton. So tauopathies are divided into a couple different kinds, and that's based on the number of predominant tau isoforms that are found in the cytoplasmic inclusions. They can be either 3 repeat or 4 repeat. And there's actually the tau that's involved and implicated in Alzheimer's disease is a 3R, 4R. So you see both 3R and 4R in pretty equal ratios. That's also what's seen in chronic traumatic encephalopathy, though that's one we still don't know a whole lot about. So when tau is accumulating in a pathologic way, inclusions lead to conformational changes and protein misfolding. And so tauopathies are defined by this 3R, 4R distinction, but there's also a number of ways that these tauopathies are divided and defined based on the actual appearance of the inclusions and their morphology. So starting over on the left, one of the 4R tauopathies, progressive supranuclear palsy, you'll see these abnormal aggregates of phosphorylated tau in portions of astrocytic processes near the cell body. So they're happening close to the cell and they look like a little tuft or sometimes described as the cheerleading pom-pom. And the pathology here is not actually neuronal, but actually glial instead. And if you look at the next box, another 4R tauopathy is corticobasal degeneration. So similarly, there's abnormal aggregates of phosphorylated tau, but these aggregate more in the distal portion of astrocytic processes and tend to appear more overall patchy or wreath-like. And again, this is glial, not neuronal pathology here. And then PIC bodies, on the other hand, are a 3R tauopathy. These look like these very dense spherical inclusions, and those contain tau fibrils that are sort of arranged in a disorderly array, and these are intracytoplasmic. Just for reference, though we already reviewed the Alzheimer's disease neuropathologic change, that fourth box there, that's what the tau tangles look like in Alzheimer's disease. There are these sort of flame-shaped intracellular aggregations, and again, comprised of abnormally phosphorylated tau. So these pathologies all look different when you look at them under a microscope. We don't have a way yet of being able to test directly for these proteins while people are still living, but hopefully someday. And for Alzheimer's disease, we do, but nothing else so far. Next up is TDP43 or TAR DNA binding protein 43. This is probably the most recently discovered. So TDP43 was first linked to ALS and FTLD in 2006, which really is not very long ago. We actually have patients sometimes who come in and have an autopsy for one of their parents that was done, in the 80s or 90s. And it's stated, oh, it's not Alzheimer's disease, but it's sort of an indeterminate temporal predominant dementia or frontal temporal predominant dementia, which we assume disease process. They just didn't know how to identify that yet. Those are always really interesting when we see sort of the historical autopsies that predated our current understanding of these diseases. So TDP-43 in a healthy state is involved in the regulation of RNA processing. When it's happening pathologically, that it can mislocalize from the nucleus or abnormally aggregate in cytoplasmic inclusion bodies. So there are a number of ways that these pathological processes actually present, and sort of a number of different visual appearances of these on a microscope. And that allows there to be sort of identifiable subtypes of TDP-43. And the categorization of these subtypes depends on three key features. So the presence or absence of cytoplasmic inclusions, presence or absence of internuclear inclusions, presence or absence of dystrophic neurites, and then also this categorization depends on where you find these inclusions in the cytoarchitectonic layers, sorry. So we won't go through all of these examples because I know there's a lot of different types, and we're not going to go too far into really what these types are, but I just want you to know that there are these sort of identifiable differences in the way that TDP-43 proteins actually present. So for example, type B is mainly cytoplasmic inclusions, those sort of dark blue little nodules there. And those range from both the superficial into the deep layers of the neurons. Whereas if you look at type C, it's really primarily dystrophic neurites. They look like little squiggles there, and those are limited to the superficial layers. So these have all been defined in the literature, and they're sort of specific visual differences, but also different relationships to where in the brain these things tend to show up and what symptoms are associated with them. So last but not least, for our very brief simplified overview of proteinopathies, are Lewy bodies, or alpha-synucleinopathies. So alpha-synuclein modulates DNA repair processes. So when this is occurring in a pathological way, when these processes are reduced in Lewy body bearing neurons, those DNA repair processes are altered or interrupted. These look like spherical masses in the cytoplasm. They tend to displace other cell components. And this is a nice image down on the bottom left there of the cortical Lewy body. And alpha-synucleinopathies, especially what we think of as sort of a classical Lewy body disease, is not really a focal disease. So it first accumulates in the brainstem and then eventually spreads out more diffusely. But generally, there really is spread of Lewy bodies into the rest of the cortex if you're looking at a pure, true sort of diffuse Lewy body disease. So that is a lot of information that I've just thrown at you. And again, you do not need to remember the details, but it's really just to give a sense of kind of the overview of the different types of diseases that we are working with here. So that brings us to kind of the crux of what I want to talk about today, and that's clinicopathologic concordance. So how do we integrate diagnosis of dementia syndromes with our understanding of and diagnosis of an underlying disease? So we have our distinct syndromic diagnoses that we're able to assess for based on symptoms, signs, cognitive testing, all the things that we do as neuropsychologists. And we have our array of proteinopathies. So this is just for illustrative purposes here. It would be nice if, we had these 4 different categories and each one of them corresponded perfectly to one of the underlying diseases. So Alzheimer's disease always causes progressive amnesia. Lewy body disease always causes progressive visual spatial problems, et cetera, et cetera. So unfortunately, or not necessarily unfortunately, but realistically, this is not at all the case. So in fact, heterogeneity in these relationships is actually the rule here and not the exception. And the way to think about dementia heterogeneity is that the same pathology can cause different dementia syndromes. And conversely, a single dementia syndrome can be caused by multiple pathologies. So rather than simple one-to-one pathways between a pathology and a syndrome, our current understanding of clinicopathologic concordance looks more like this. So certain syndromes are more likely to be caused by certain proteinopathies, but the concordance here is probabilistic in nature. It's not deterministic or one-to-one. So, and this is again, a very overwhelming table, but I think it's important to kind of look at the fact, especially in, let's say, the aphasic and the behavioral type dementia syndromes, those can really be caused, and we've seen cases of those being caused by a whole array of different proteinopathies. So that's where things get really interesting and things get a little bit messy in terms of our ability to predict what someone's underlying diagnostic, what their disease is. So this is the same table as we were looking at before that looked at kind of the syndrome level diagnosis of these different types of dementia phenotypes. But now we have probabilities included for how likely it is that that type of presentation is caused by a specific type of pathology. So, we still see that a progressive amnestic presentation is most likely to be caused by Alzheimer's disease. Similarly, a progressive behavioral presentation is most likely to be caused by some type of frontotemporal lobar degeneration, which includes both the tauopathies and the TDP-43 proteinopathies. Again, things get a little bit more interesting in the field of progressive aphasic dementias, where it's pretty evenly split between Alzheimer's disease, FTLD tau, or FTLD TDP-43. But the different types of subtypes, are more or less likely to be caused by certain types of pathologies. So one question that you might sort of have at this point is, why are we trying to focus on both? And why is it important if we do have biomarkers, or if we are able to identify the underlying disease, why would we need to diagnose something as a syndrome? The biggest answer at this point is we just are not there yet. We do have pretty reliable CSF biomarkers for Alzheimer's disease, and there's a bunch of serum or plasma biomarkers that are kind of in development for Alzheimer's disease, but this is not the case for really any other proteinopathies. So we're limited in terms of how confident or how certain we can be that someone has a specific pathology while they're still living. The other thing here is that while we hope and expect that there will someday be disease-modifying treatments for these diseases, they don't exist yet. The only exception to this is the recently approved anti-amyloid treatments for Alzheimer's disease, which did show the ability to clear amyloid from the brains of people who were in the study. However, the clinical outcome and the evidence of the impact of that clearing of amyloid on clinical outcomes is still kind of up in the air. It's a little bit tenuous. So we have this very limited set of people who might start receiving these treatments in the next weeks and months, and hopefully that is helpful. But the reality is most people are still going to be mainly managing dementia on a behavioral symptom-focused level. So understanding patterns of cognitive strengths and weaknesses, identifying sort of the clinical phenotype, is actually very important and incredibly helpful for patients and for their families and care partners. That's where we really can do the bulk of management and intervention, getting people set up with social work, various resources, care in the home, things that actually support their sort of day-to-day well-being and their functioning. Someday, hopefully, that will be accompanied by very effective disease-modifying treatments, but we have to kind of focus and still be able to manage, what comes into our clinic now. So the other thing why it's important for us to both assess syndrome and disease is that they don't, correspond one-to-one. So even if you diagnose the syndrome, you can't be certain that the underlying disease is going to be what you think it is. On the other hand, if you have a positive biomarker, let's say you have positive Alzheimer's disease biomarkers, you can't say 100% that's going to mean that person has an amnestic pattern of symptoms. And the way that it sort of helps to make sense of that is that syndromes reflect, and the symptoms that we see reflect more where the pathology is and not what. So in many cases, it matters less what the actual proteinopathy is, but it matters where it's hitting in the brain. And one of the most sort of elegant examples of this comes from primary progressive aphasia, or PPA. And this primary progressive aphasia was first described by Dr. Meselem in 1982, and it's defined as a language dysfunction. So it's aphasia that's progressive and is the primary domain of decline, at least in the very beginning of the course of symptoms. PPA is also a really good proof of concept for the idea that symptoms are defined by where and not what the neurodegeneration is. So compared to Alzheimer's disease, which tends to be relatively symmetric or bilateral, the hallmark feature here for PPA is asymmetry in neurodegeneration. So again, for persons with typical left lateralized language function, PPA is associated with predominantly left-sided atrophy, also predominantly left-sided functional changes, and predominantly left-sided pathology when you look on autopsy as well. And this is the case regardless of the underlying pathology. So there's this really stark asymmetry, no matter what the underlying proteinopathy is. And if we think or look sort of in a little bit more detail at the specific subtypes of PPA, and this is one area where neuropsychology is very helpful in diagnosis, because we're able to assess the patterns of language impairment or language deficits that can help inform both what the diagnostic, the likely disease is, but just generally how someone's functioning in their daily life. So the first on the top here, logopenic PPA, usually presents with word finding hesitations, phonemic paraphasias, and that's associated with neurodegeneration in the temporal parietal region of the left hemisphere, assuming normal, typical left lateralized language dominance. Whereas if you look at achromatic or non-fluent PPA, the one in the middle there, this tends to be much more associated with frontal atrophy and hypometabolism, and presents more with abnormalities in syntax or other aspects of grammar. If you look at the common pathology for logopenic PPA, it's most commonly caused by Alzheimer's disease, but not always. Similarly, achromatic PPA is most commonly caused by FTLD tau, but not always. And then semantic PPA down at the bottom, so that presents with abnormalities in single word comprehension and recognition, and is thought to be sort of a loss of word knowledge, less so than a difficulty with word retrieval or word fluency. And in these cases, neurodegeneration is typically very sort of strikingly focused in the temporal pole, usually the left temporal pole. But again, across the board, key denominator here is asymmetry, and typically left-sided asymmetry and atrophy in the brains of people with PPA. So there's also been work at our center that sort of defined clinical phenotypes of Alzheimer's disease in both amnestic and aphasic cases. So in this case, what you see is that there's reliably asymmetry in the density or the location of neurofibrillary tangles in PPA, but not in amnestic dementia cases. So what that means is that you see about the same number of tangles in the right and the left sides in PPA, or I'm sorry, in amnestic dementia, whereas in PPA, like this example shows here, the left area of the brain is sort of heavily propagated with tau tangles there, and the right is very much not. The interesting thing is that is true for tau tangles, but not for amyloid plaques, which sort of lends more support to the idea that I think we've seen come up more and more in the research, that tau is actually more predictive of clinical symptoms than amyloid in Alzheimer's disease. So one other thing that we sort of have to grapple with is we know that certain proteinopathies are sort of more likely to attack certain areas of the brain. And one way that we can understand this is the idea of selective vulnerability. So this is sort of a broader term, but it just means that certain neurons are more prone to abnormal function or death in response to specific pathological states or injury. So if we look at the spectrum of tauopathies, including both 3R and 4R and 3R, 4R, this is a good example of this. So this is a sort of an image of where in the brain each pathology tends to sort of focus. You see with Pick's disease in the red, more frontal temporal, compared to Alzheimer's disease, much more focused in the medial temporal lobe and the hippocampus and the basal forebrain. Cortical basal degeneration involves more involvement of the motor centers of the brain, so the basal ganglia and the primary motor cortex. And then progressive supranuclear palsy, or PSP, tends to be, more focused in the brainstem, although also the basal ganglia as well. So we see this. We see that these different tauopathies tend to hit different parts of the brain, but we still don't really know why. So that's one of these big mysteries in the field. We know some risk factors for certain types of diseases, but in the absence of a clear genetic mutation, which are very rare in most of these diseases, we really don't know why specific people develop specific proteinopathies. And that's, I think, an area where hopefully we'll continue to learn more in the coming years. And I just want to take this a little bit of a tangent as well, but I think very relevant when we're talking about syndrome versus disease, just to talk a little bit about the current context of the definition of Alzheimer's disease and the way it's diagnosed. So I referenced the criteria from 2018 earlier, but the NIA and the Alzheimer's Association have actually released a draft diagnosis of updated clinical diagnosis guidelines just this summer. And this was interesting because the focus has been, over the past couple of decades on sort of more of a biological definition of Alzheimer's disease. So that would require, if we're going to diagnose someone during life, we have to be able to give an accurate read of in vivo biomarkers. We have to have a way of measuring the proteinopathy and the changes in their brain. So we can do that with CSF biomarkers, and if they're positive, that's a very sensitive, specific signal that they do have Alzheimer's disease. I think in our center, we've yet to have someone in the brain bank who came in with positive, like squarely positive CSF biomarkers for Alzheimer's and then didn't have Alzheimer's disease on autopsy. Sometimes they had comorbid pathologies, but it's typically pretty accurate if it's positive. When it's not, when it's borderline or it's inconclusive, we don't know as much what to make of that. And similarly, PET biomarkers for Alzheimer's disease are less specific, less sensitive than CSF biomarkers. So we just don't have really reliable biomarkers outside of just the CSF testing. But this updated draft criteria really focuses on diagnosis based on any positive biomarker. So any positive biomarker is sufficient for a diagnosis, but clinical symptoms alone are not. So if you had someone who had the perfect typical amnestic presentation, you wouldn't be able to say that they have Alzheimer's disease unless there's biomarker evidence to go along with that. So one thing I think that does factor in here, I mentioned the newly approved anti-amyloid treatment. So lecanemab or Leqembi is what people are starting to get now. And then donanemab has published promising results over the summer, but is awaiting an FDA decision. So this has been sort of a huge topic of discussion for us in our clinic. It's obviously a huge deal and I think a great source of hope that there is a new drug and there's this new class of drugs and they do something. But I think it's also been, our neurologists have been pretty cautious and I think understandably cautious in their enthusiasm. And that's really because they do what they're set out to do from a biological standpoint. They remove amyloid from the brain. But the corresponding clinical outcomes were very modest. And it's difficult to measure, difficult to make sense of and sort of understand whether there's meaningful change. This again points to this idea that amyloid is not often associated really closely with symptoms. That tends to be tau more so. So if you're removing amyloid in the brain, we don't necessarily know exactly what the impact is going to be, but you wouldn't necessarily predict it's going to be a huge change in symptoms. But this is sort of late breaking news for our field to have, a new medication that does do something for Alzheimer's disease. But I think we have a long way to go before we can actually say that we're curing or treating Alzheimer's disease. And another kind of thought just generally that always comes to my mind, and it's something we think about a lot and talk about a lot in our clinic. So explaining dementia and neurodegenerative disease is clearly incredibly nuanced. There's actually a dementia nomenclature initiative that my mentor, Sandra Weintraub, is involved with that's been convening for like 7 years now to try to address the variability in terminology that we use across the field. Some of that variability comes from just different uses for diagnosis. So for research versus clinical, obviously, if you're trying to research disease-modifying treatment, you want to know exactly what disease someone has. If you're trying to manage symptoms, it really doesn't matter so much. And what we find is that, patients always ask us, well, do I have dementia or do I have Alzheimer's? And so there's really been kind of a lack of communication to the general public about what we're talking about when we talk about Alzheimer's, what we talk about when we're talking about dementia. And that's true also for just other medical specialties. So, I live in a very specialized professional environment where we all focus on dementia. We have a brain bank, we're constantly learning new things, but these things don't necessarily trickle out more broadly than that with any regularity. So I think we have a lot of work to do as a field to really help both our colleagues and our patients understand, what we're talking about and what we mean when we say a diagnosis of dementia, what we mean when we say we think it's caused by this underlying disease. So my main takeaways here are really that this relationship between a clinical syndrome and the underlying pathology is probabilistic and definitely not absolute. Exception. And just remember that the same pathology can cause different syndromes, and the same syndrome can be caused by different pathologies, which is a really important concept and sort of shakes up your more traditional understanding of dementia syndromes. We suspect that selective vulnerability of neuronal populations helps lead to sort of the specific clinical phenotype that you see in any given patient. And these symptoms are determined by where the pathology is, not necessarily what it is. And then just to echo again my thoughts on terminology, just that it's important to be specific when you're talking about these diagnoses with patients and families, but also just with each other within and outside of our field. We've actually had, a lot of patients that really do understand what we mean once we have the time to sit down and talk with them about, this is the limit of our understanding. I think it's important to know what you don't know in this field. And that's honestly probably the thing I've learned the most in the last couple of years working at the Measurement Center is, where are we actually certain about something? And beyond that, how can we communicate in a way that, doesn't just create a sense of confusion, but isn't sort of overstepping our understanding. It really focuses on what they need to know in terms of, what they're going to experience, likely, how their families and their care partners can help support them. I just also want to thank everyone at the Measurement Center, obviously also our patients and families that give just so much of themselves and even give their brains to allow us to do all of this research and learn about these diseases. Special thanks to Tamar Geffen, who very generously let me borrow a lot of her slides and also continuously lets me borrow her expertise whenever I don't know what I'm talking about. And all of the members of her lab who created some of these amazing figures that you saw in the presentation today. And then hopefully we have a little bit of time left for some questions.
All right, thank you, Dr. Mather. I do have a couple of questions. So I guess the first one I'll ask is, how do you think neuropsychologists in general should incorporate knowledge of these underlying pathologies into our conceptualizations, even like test selection, if you think that actually has a bearing on how we would make those decisions? Since, as you were saying, these etiologies, these biomarkers are really hard to measure in vivo.
Yeah, that's a great question. And to some extent, it matters like what kind of environment you work in. So I am lucky enough to work in a very interdisciplinary clinic. So our neurologists are the ones who are ordering these biomarker tests. They send, to us for testing. Often they also see social work within our same clinic. So for us, I think there's this kind of seamless integration between those things. So if you're never going to be able to get, either someone's never going to pursue biomarker testing or there just isn't a local resource to do that, the likelihood that they need to know exactly what underlying disease is causing the symptoms at the end of the day, if you're really just trying to help them understand like what they're doing on a day-to-day basis and what's likely to happen, I mean, part of the desire to know exactly what disease someone has is more of a scientific and sort of an understanding based question than a helpful one for patients. We often do have patients who desperately want to know what's going on and desperately want to know what disease it is and be able to keep up with publications on, that disease. So it depends. And certainly though, I think if you are able to sort of facilitate that kind of experience of meeting someone where they're at with the knowledge that you can provide, I actually think we're really well poised as neuropsychologists to kind of help that make sense to someone. And we have a little bit more time with them often. It's a little bit harder, I think, in the span of one neurology appointment to help someone understand, what we mean by all these words that we're throwing at them. So yeah, I would say, it's helpful to keep in mind what the patient's goals are too. Some people don't really want to know, and if we're just treating the symptoms anyways, then what's the point of biomarker testing? We have people like that come in all the time, but we also have people who are like, I will do every test that you have. I want to know exactly what's happening. So you got to kind of, meet people where they're at, but obviously our understanding as a field, and sort of our research base of knowledge about this depends a lot on our ability to make those kind of correlations between what's happening in someone's symptoms while they're still alive and then what we would see in their brain afterwards.
Yeah, I think you kind of predicted my next question, because I was
Oh, great.
thinking of given those updated NIA draft criteria putting more weight on biomarkers. When biomarkers are inconclusive, like how do you
Yes.
go about having that conversation with patients about the uncertainty of the underlying disease process?
Yeah, it's challenging. It's very confusing. And I think we all often feel this just in this field. It's like, it's so confusing for us. Like our understanding of the sort of boundaries of different diseases and different clinical phenotypes is constantly changing and moving. And so I always really try to remember the limits of my own knowledge in this case and really try to kind of communicate that not as like from a defeated stance of, oh, we just don't know and we'll never know, but more from the stance of, we know these things about this kind of disease, but we don't yet have a test that's going to tell us exactly what it is. And sometimes it helps to kind of emphasize, well, if we want to prescribe this medication, then it might help us to know whether or not it's this kind of disease. But sometimes you might just find that people will try the medication anyways. If it's helpful, great. If it's not, don't keep taking it. And a lot of the symptom, like really, I would say the most meaningful interventions that we have are what our social work team does, in terms of just helping people find resources and manage symptoms on a behavioral level. We send a lot of our patients for speech language pathology, either to work on, communication or just generally sort of implement compensatory strategies. So I mean, this is an area where I think humility is really important. Not that it's not important everywhere, but I think we just know so little still about neurodegenerative diseases in general, that it helps to be able to identify how far we are away from being able to actually just treat a disease. Because we have patients come in all the time who are like, well, I just want you to fix it. And I'll do anything to get the thing that's going to make me normal again or fix it for me. And you have to hold a lot of that, pain and uncertainty with them and not be scared to give them an answer that's, well, we don't know, but this might be helpful to determine if this treatment is helpful, or what I think would be helpful is actually just working with, a therapist or someone who's going to help you coach, figure out some compensatory strategies in your life. So that's maybe a somewhat unsatisfying answer in that the answer basically is it's hard.
Definitely.
Yeah.
Okay. Yeah, I see another question about sort of looking into the future of neuropsychology. Do you see a scenario where maybe like we would follow patients to death and then be seeing autopsy confirmed pathology to confirm our tests, or maybe less utility for some of the tests?
So that's absolutely where,
No, no,
and
go
sorry
for
if I cut you off with more question, but I just want to say that's essentially what, I mean, I feel incredibly privileged to work in an Alzheimer's disease research center because that's what we do from a research standpoint. So people in our research center, we follow them yearly. They almost always donate their brains, at the end when they've passed. And that's where the bulk of our sort of new understanding or knowledge has come from. So I think that thankfully that infrastructure already exists on a research standpoint. And we often follow our patients who are not necessarily enrolled in research, but we tend to follow them relatively regularly. So we kind of get to do that a lot of the time. And if it's a really kind of head scratcher of a case, sometimes we'll bring them in on research because, the best thing that we're going to be able to give their family in some ways is an answer at the end. And people can still get autopsies, outside of research, but often that's, a help for the family to be kind of involved in something and have an answer at the end. But I mean, I think that is kind of the best option for a lot of cases that otherwise you just won't ever really know. You might be pretty certain, but yeah, that's kind of our clinic kind of functions in this model of following people really as long as we think we're useful for them and as long as they're willing and able to come in.
Awesome. I think we have time for maybe like one or two more. So I'm seeing a question too about since part of the focus that you were discussing was this differentiation of the different PPA syndromes and how they do have these underlying pathologies to some extent. And there's a question about how, because that's such a language-based disorder,
Yes.
how different languages may manifest or different like cultural variables may moderate the relationships between those pathologies and the syndromes.
Yes, that is a great question. And in the interest of following my own advice, I think we just do not know the answer to that question. It's such a rare presentation, PPA in general, among dementia syndromes that we see relatively few of them, even though we probably see more of them than most other dementia centers or memory centers. So the unfortunate current answer to that is I don't think that we know, but I think it's an incredibly important question. And I think, I think in many ways that would impact sort of the presentation of symptoms more than anything else. So we kind of know like what parts of the brain, at least in our participants that are in the research studies that speak English, and most of them are monolingual English speakers. We kind of know what areas of the brain we think are related to different things. So if one subtype is related to this certain area of neurodegeneration, we think we have an idea of that, but the reality is that those things haven't been studied in any real, reliable or meaningful way. At least not at our center, certainly. And that's not to say that this research isn't happening, around the world, but it's hard to get a big enough sample of people with PPA to be able to sort of draw those conclusions. So I think that'll be really important going forward to focus on.
Yeah, it sounds like that's probably in a lot of spheres of neuropsychological research, that is one of the big things. And
Yep.
we all know there are some efforts underway to kind of right that shortcoming. But I think that kind of draws us to the end. So thank you so much, Dr. Mather, for your awesome presentation. I want to, yeah, absolutely. All right, so I'm going to also direct all the attendees to the next lecture that we have coming up, and that is going to be a lecture by Dr. Lana Harder about increasing access to care for kids through teleneuropsychology. So thank you everybody for joining.